Well, all of us know that back pain has multiple sources. The commonest is discogenic, and discogenic pain also can cause radicular pains. You have facetogenic pain, and that also can cause radicular pains, different varieties. The most important cause of any chronic non-responsive back pain is our inability to localize the pain source. That's extremely important. We speculatively keep treating them. These pain sources, especially in the lumbar spine, could be multifactorial, multi-segmental. Somewhere it could be L3-4 left side, it could be L4, L5 at right side, and somewhere down in the disc at L5S1. They could be single or multiple at the same time, and it's very, very difficult to speculate that what looks bad is the source of pain. The question arises, is the abnormal looking area always the pain source? Because the pain source often is non-radiological. It could be inflammatory cascade which is causing pain, or autoimmune local events. The nuclear protein is a notochordal protein, gets sealed up at the age of 3 to 4 months intrauterine life, and our reticuloendothelial system, which forms at the age of 7 months, does not get introduced to it. So when there is a first rupture, a first injury, where these proteins come out, the body starts fighting with them. And that can happen. Now, such events are not really measurable. They're not really seeable in any way. Truly speaking, any speculated pain source remains as a probable source until you block it and the patient gets pain relief. Then only I can really vouch and say, yes, that was the pain source and the cause of pain. Well, for any reliability, accuracy, safety, we need image intensifier control, which is what we are commonly used to. Proper positioning of the C-arm is extremely important also. And we must use radiographic contrast, because that will ensure therapeutic medicine reaches the correct pain source. Like you can see here, the needle in the spine with a local radiculogram and epidurogram. Well, C-arm-wise, hundreds of models are available, but it must be optimum and minimally powerful, good enough to give a good quality lateral view image of a lumbar spine in an obese person. One of the important abilities it must have is about shooting video. And of course, you must have a well-experienced C-arm handler. The question arises about the exposure. Many people say that radiological exposure is too bad. There are plenty of papers on that paper, plenty of work done. These are 3 main papers, landmark papers, and they have concluded that the average exposure during these procedures was below the limit of detectability if you use proper precautions. The interval exposures are better than daily exposures. The pulse mode can reduce radiation exposures to a very reasonably low level, and image quality on low dose also can be adequate enough for you to work. So when we use the procedure, we say follow radiation protection. We keep our hands off the beam using long-handled instruments. We hold the needle with a long needle holder. We have a localizer ring of a swab holder. Use them as a marker. Then we shoot a pilot image, use auto exposure, and then reduce the exposure. Improve the image by monitor adjustments, brightness contracts. Use pulse imaging, and we don't do it daily. We alternately do, my colleagues do it alternate day or twice a week, something like that. Our table has a way back extended or far away eccentric column, and we put the patient totally prone. We don't put oblique, 45-degree rotated, etc. This way the patients are very comfortable, they are very stable, and their compliance is very excellent. Whatever we want to look at the image, we make changes in the C-arm, and that's why I said you must have a good C-arm handler. Well, injection modality, indications are common: local pain with referred pain, radicular pain per se, and of course trigger spot. And the contraindications for any injective procedures will be progressive neurological deficit, Cauda-Equina syndrome, uncontrolled diabetes, bleeding probabilities, and of course, local infection. Mainly 3 drugs are used: local anesthetic, corticosteroids, and sometimes pure analgesics. Of all the people, corticosteroids have a lot of a role to play because they facilitate the neural conduction, they stabilize the membrane potential, they desensitize nociceptors, they suppress the ectopic discharges, and of course they prevent adhesion and scarring. All in all put together, they give a good pain relief, and that pain relief period must be used exhaustively for the rehabilitation process. There must be an excellent familiarity with the orientation and...
Thank you.
7 minutes. Okay. Excellent orientation of the 3D images. Our method is which significantly reduces radiation exposure, improves accuracy. We select a safe bony location near the target area, and we call this as a target point for the needle tip. We keep this in the point in the center of the screen, reach this point keeping the needle in axial end-on view, and the needle travels what we call coaxial needle travel. Then later on, we navigate the needle tip to the required area. So here you can see the needle is trying to go in the Kembin's triangle to go for injecting a root. Then we manipulate it further. Then we check it in AP view, check it in lateral view, and then suspected pain source is injected one by one. We don't inject all of them together. We inject one, wait. If required, we take the patient down, ask him to do examinations, etc. Post-injection clinical examination is very, very important. Patient is asked to perform the actions which were painful pre-injections. And then only we can really make out what's going on, and we inject it further. I'll wind up here. Let's talk something in questions.